Good evening, everybody. I'm Dr. Joseph from CMC Vellore, and I shall be speaking to you on the MRI of HCM with a review of recent literature. So the AHA guidelines describe HCM as left ventricular hypertrophy, which is not explained by abnormal loading conditions. So the LV wall thickness is taken to be more than 15 millimeters. The normal wall thickness is considered to be 11 to 12 millimeters. And any degree of wall thickness with HCM genetic substrate is considered significant. So what is the pathology of HCM? There is abnormal myocardial thickening and fiber disarray. There is inefficient shortening, contraction of the heart, impaired relaxation, and LVOT obstruction. And this leads eventually to malignant arrhythmias. There is a genetic association with more than 1,000 gene mutations. These are the most common 2 mutations. However, the currently used genetic panels identify only about 60% of individuals with genetic basis. There is both replacement fibrosis as well as interstitial fibrosis in HCM. What are the different patterns of HCM on imaging? It could be symmetric or asymmetric. Asymmetric is the most common type. There are different shapes of the septum. It could be a sigmoid-shaped septum, an asymmetric septal reverse curve. Then it could be a mid-cavity where the obstruction is at the mid-cavity level, or it could be at the level of the apex where it's called apical. If it is symmetric, it resembles hypertrophic. Cardiomyopathy resembles hypertension. So this is a diagrammatic representation to explain what hypertrophic obstructive variety of cardiomyopathy is about. So there is thickening of the septum at the outlet level. This illustrates SAM, where there is anterior motion of the anterior leaflet of the mitral valve during systole. This leads to obstruction, and this is a jet due to the LVOT obstruction. And there is also a mitral regurgitant jet. So this is HOCM as seen on MR imaging. So the SAM motion is illustrated here, as well as the jet due to LVOT obstruction. And on delayed enhancement imaging, which is done after injection of gadolinium, there are focal areas of enhancement. This is a cine image illustrating the SAM motion. This is the anterior leaflet of the mitral valve. This is the posterior leaflet of the mitral valve. This is the left ventricle with a grossly thickened LV hypertrophy, which is especially at the outlet level. This is the jet, which is passing into the LVOT, and this is the subsequent mitral regurgitant jet. This is a mid-cavity variety of HCM, and we can clearly see that the maximal thickening is at the mid-cavity level. This is a 4-chamber view, which resembles the 4-chamber view in echocardiography. This is an apical HCM. So this is the RV, this is the LV, the RA, and the LA. And the maximum thickening is in the apical region. During systole, there is obliteration of the lumen. There are certain soft markers which may be present in HCM. For example, there could be an apicobasal bundle. There can be abnormalities of the mitral leaflet. So you can have elongated anterior or posterior mitral leaflets. There can be absence of caudate tendinae or parachute mitral valve leaflets. There can be abnormalities of the papillary muscle. There can be more number of muscles. as well as hypertrophy of the muscles. Multiple crypts have been described in HCM. This is a CT image demonstrating a myocardial crypt. Let's move on to delayed enhancement, which is a very important feature of HCM. There are two types of enhancement described. One is a pattern where the RV inserts into the LV at the two insertion points, the anterior and the posterior insertion point, that is delayed enhancement. However, this is a normal finding also and is seen in a variety of other conditions. More specific is the patchy, cloudy kind of enhancement, which is seen in the mid-myocardium or epicardium, but not involving the subendocardium. So this is a real-life MRI image showing the finding of intense, patchy, cloudy, mid-myocardial, epicardial enhancement. This is the insertion point enhancement, which I had described earlier. So how does LGE help us? LGE identifies myocardial fibrosis, which is the arrhythmogenic substrate in HCM. And scar quantification is very important because more than 15% of myocardial mass, which is replaced by scar, has increased risk of sudden cardiac death. And in some centers, including ours, we use it as a tool for decision-making for ICD implantation. So this study included 1,293 HCM patients, which were followed up for 3.3 years. And a continuous relationship was seen between LGE percentage, LV mass, and sudden cardiac death. And 15% showed a twofold increase in sudden cardiac death event risk. So this is a very often quoted journal for the use of using a cutoff of 15%. Now this study showed that neither the presence nor the extent of LGE in the RV insertion proved to be a reliable predictor of MACE. What are the other imaging related high risk indicators? LV wall thickness greater than 30 millimeters, low ejection fraction of less than 50%, and a LVOT gradient of greater than 30 millimeters. These were the traditional markers. LGE quantification has given a new angle to the whole perspective. Let's move on to parametric mapping. What is parametric imaging? Measurement of the native T1, the post-gathered T1, T2, and ECV values. I shall not go into the details of this. But why do parametric mapping? Why not just LGE? The problem with LGE is it cannot depict diffuse processes. So this area, though it looks black and looks like normal myocardium, might still have diffuse fibrosis, which may not be picked up by this technique. This region, which is obviously abnormal, is showing patchy cloudy fibrosis by the LGE technique. And that is where parametric mapping helps us to go further. So in this study, this is the T1 mapping, this is the ECV mapping, and this is the LGE. There was no LGE in this patient, which would indicate that there is no fibrosis. This patient had septal hypertrophy, but the T1 as well as the ECV values were elevated. Look at this patient. This is T1, ECV, LGE. The patient has apical variety of HCM, that the thickening is in the apical region. There is no LGE, however, T1 and ECV values were elevated. So there was very good correlation between the native T1 ECV as opposed to the LV mass index. So those individuals with sudden cardiac death had greater T1 time and ECV fraction, as well as larger overall mass of the left. So let's see a case that we had in our hospital. This is his clinical data. These were the findings where there was asymmetric septal hypertrophy. There was no SAM, but there was delayed enhancement. The ejection fraction was 65%. The T1 value was normal. Even in the region of fibrosis, the T1 value was normal. The T1 is always compared with the control value, and this control has to be established in every center because it varies from machine to machine. The T2 value was also normal. However, the ECV was elevated. It was 40% and control was 32%. So in our study, in this particular case, the ECV was elevated, but the T1 was within normal values. And this is similar to this particular study, which says that in diffuse fibrosis, native T1 may be normal or mildly elevated, but ECV is usually elevated. So let's see what was the conclusion from this particular article. What they said was the kind of changes that we are looking at when we do T1 mapping, as well as other MRI research tools, is in the order of 2 to 6%. But 2 to 6% is within the intrinsic error of these measurements, which is roughly 10%. And this particular study, which we were looking at, they had positive results because they looked at a very large patient. So how do we apply this to patients that we see in the clinic? We can apply it, but only to individual patients who are extreme outliers. In the future, with further research, perhaps we will be able to identify all patients who will benefit from this parameter. So let's move on to the differential diagnosis of HCM. It includes hypertension, amyloid. So here the pattern of enhancement is totally different. There's a diffuse enhancement involving the entire myocardium and with subendocardial sparing. And this particular sequence is very characteristic of amyloid, where the nulling of the blood takes place after the myocardium. First, normally the blood nulls and then the myocardium nulls, but in amyloid, first the myocardium nulls and then the blood. So what about parametric mapping? The T1 was grossly increased and the T2 was mildly increased. What is typically expected in amyloid, both T1 as well as ECV is grossly increased. And in the same chart, if you have a look at fibrosis, fibrosis like in HCM is showing normal values on T1 and elevation on ECV. So there is variation in findings between studies. Other differentials include chronic renal failure, fitness-conscious patients, athletes' heart, and even conditions which are congenital, like Friedreich's ataxia. Ventricular septal bulge is normal in elderly, and there is an association between HCM and a condition called non-contraction. I will not go into the details of non-compaction here. So what is the role of CMR in hypertrophic cardiomyopathy? It helps to establish the diagnosis and phenotyping for accurate measurements to differentiate HCM from other causes of LVH, risk stratification and risk decision-making on device implantation, and for screening of family members. Let's move on to this case where the ECG showed LVH with strain. The echocardiogram shows certain findings with LV hypertrophy. The clinical question that was asked is, demonstrate the cause and the degree of stenosis on MRI as well as to quantify the degree of fibrosis. So this is an axial image through the heart, and there is very obvious gross thickening of the septum. This is a cine 4-chamber view, and it shows us that there is a jet that we are seeing here with gross hypertrophy, so very much a clue towards HCM. This is a LVOT view showing a SAM with LVOT obstruction. Note the gross hypertrophy again. There are abnormal mitral valve leaflets. There is no chordate tendinae here. The leaflet is directly attached to the papillary muscle. This is the delayed enhancement image, which shows focal areas of fibrosis. These are different views in which it is taken. This is a short axis view, and the fibrosis seems not really in proportion to the degree of hypertrophy. This is the LVOT view showing the same finding. And this is an example of flow imaging which can be done using phase contrast technique to calculate flow across the LVOT here for. And this shows the flow parameters. This shows the ejection fraction to be 58% and then normalized values. So that was a case of HOCM. Let's move on to another case. This is the initial axial view, which we do for all cases, which showed a lot of LV hypertrophy. But look at the pattern of hypertrophy here. The thickness is in the mid-cavity region, and this kind of hypertrophy pattern can lead to an aneurysm formation in the apical region and thrombus formation here. This is the 2-chamber view. This is the short axis view. This is the LVOT view. And there is opposition of the two walls during systole. This is the delayed enhancement view showing patchy focal multiple areas of enhancement, which indicates fibrosis. And there is more severe fibrosis as we go towards the mid-cavity and apical region. So the same pattern here. There is extensive fibrosis as we go towards the apical region. So here the quantification will definitely be more than 15%. And so this patient was managed conservatively and put on follow-up. This patient had inverted T waves, and inverted T waves are a giveaway for the diagnosis of apical HCM. So if we look at the pattern in this patient, there is complete obliteration of the lumen during systole. This finding can be missed easily on echocardiogram because it's difficult to assess this inferior wall on echo. Let's look at the delayed enhancement pattern. Difficult to see it on the short axis, but when we look at it in the four-chamber view, there are patchy areas of fibrosis. Yeah. And the normalized values are given here. This last patient had HOCM and went on to have a septal ablation for the same. And this area is due to injection of alcohol and scar formation, which very much resembles an infarct. So one of the complications of injecting alcohol is future arrhythmia. So following the procedure, there was drop in the LVOT gradient. Okay, so some of the recent studies that have been done, do I have time to go through it? Dr. Juliet, how much time do I have?
I'm sorry, but we're cutting close on time, so just a couple more minutes. Thank you, Dr. Joseph.
Yeah. So this study went on to show that even the non-hypertrophied segments showed significantly elevated T1 and T2 values, indicating that they were abnormal. This particular study went on to show that myocardial strain imaging, which can be done in MRI similar to echo, is also a useful technique to detect abnormalities. Fractal analysis is yet another technique to indicate abnormal pathology, and this is by looking at the apical fractal values. OD flow imaging can be used to assess LA kinetic energy. T2 star bold and T1 mapping techniques are now available. And with that, I would like to conclude by saying that I'm part of an association in India, which was established in 2010, and we collaborate with other like-minded societies. So if any of you would be interested in collaborating with us, we would be very happy to join hands with you. And this is a traditional Indian thank you. Namaste.
Thank you very much, Dr. Joseph. I'd like to open the floor now to any questions to Dr. Joseph.
I would like to ask a question. Hello.
Yes, tell me.
My name is Carmen Maria Moldovan from Denmark. Very nice presentation, many informations, nice images. I would like to ask you, athletic hearts with left ventricular hypertrophy, we always have a question or are afraid that it is a normal left ventricular hypertrophy always seen in athletes, or is something else? Are you using a low threshold for MRI in these cases? Thank you very much.
No, the threshold for suspicion is similar to that of echocardiography. And we use 15 millimeters and above to diagnose HCM, unless there is a family history when we use 13 millimeters as a cutoff point. Usually, athlete's heart is less than 15 millimeters in dimension. But if there is some borderline case, what is recommended is to decondition them. So to make them stop doing their exercises, keep them on follow-up, and if it's an athlete's heart, it should revert back to normal. It should reduce the LV wall thickness by 2 millimeters or more, whereas HCM will not become normal again.
Thank you.
Thank you. Thank you for the question, and thank you again, Dr. Joseph. And I would now like to invite Dr. Julian